Good afternoon and welcome to Webinar Wednesday. We're excited to have over 300 registered attendees for today's webinar, which is eligible for 1 credit from the ACI. Let's get started by giving one lucky attendee a Webinar Wednesday t-shirt for answering this trivia question. Our sponsor today, Medigate, is headquartered in New York. Which movie actor born in New York played Iron Man in the Marvel film series? Answer now using the questions feature on your dashboard. While you're answering, I just want to remind everyone that if you've missed any of our previous webinars, you can watch them on our website, webinarwednesday.live, and you can still receive a CE credit as well. Okay, let's see who the winner of our Webinar Wednesday t-shirt is, and it is Todd Forsch. Congratulations, Todd. Of course, the correct answer is Robert Downey Jr. Webinar Wednesday would like to thank our sponsor, Medigate. Medigate's comprehensive and accurate device discovery capabilities, combined with clinical contextual anomaly detection, enables automated, rule-based, clinically driven security policies that keep clinical networks and patients safe. For more information, visit medigate.io. Our presenter today is Joseph Ouellette, Clinical Systems Engineer at Yale New Haven Health, and our moderator is Tom Finn, Director of Business Development at Medigate. Tom, you may begin whenever you're ready.
Well, thanks, Linda, and welcome everyone. Quite a crowd. By way of a little personal background that I think is relevant to today's topic, having facilitated technology transfer, meaning software development and creating demand for that software, specifically into the acute care subvertical of healthcare for almost 3 decades now, I'm afraid to say, I am very familiar with the industry's tech adoption curve. And I have to say, I've never seen it compress like it has around IoT cybersecurity, the solution market. Clearly, it's a testament to the shared urgency we all have around solving the problem. It does mean, however, that health systems that traditionally waited a few years to see how things shake out, for example, to assimilate the experience of folks like Joe, who's on the phone today, they're moving forward without that benefit, and naturally their evaluation process is reflected. And with a vendor community chock full of websites, PowerPoints, and general messaging that is all strikingly similar, it exacerbates the problem, makes it very difficult for everyone, even the vendors, to discern hype from reality. A vital mitigating strategy to this problem, one that I know will ensure far better outcomes, including a superior long-term foundation for cybersecurity program development, is to assure upfront cross-functional participation, starting with the evaluation phase of the solution market and ongoing. More in different ears, more perspectives, et cetera, it's better, especially when factoring in healthcare's notorious resource constraints in this realm. Hence our topic today, IoT cybersecurity is a team sport. So with that, Joe, would you kindly introduce yourself to our audience and share a little background, and then we'll get right into our interview.
Thanks, Tom. My name is Joe Ouellette. I'm a clinical systems engineer for Yale New Haven Health System. I graduated from UConn in both undergrad and graduate in biomedical engineering and clinical engineering. I did my internship in the clinical engineering program at the VA in West Haven, where while there I started doing a lot of projects that entailed working with the IT department and doing a lot of networking and looking at our medical equipment that was connected to the network. And that really started my whole thought in how I could move forward in my career. From there, I went to Yale and got a job doing biomedical device integration, connecting medical equipment to send information to our Epic medical record as we were deploying Epic across our health system. I've also since acquired a second master's degree in healthcare informatics that helped me to sort of view that IT side of our environment a lot better. And now as a clinical systems engineer, I'm working between IT and other parts of the hospital, as well as clinical engineering and all of our medical equipment, and really trying to keep everything in mind as we move forward.
Well, Joe, Yale New Haven, for those who don't know, I would assume most do, is known as a quintessential early adopter of new technologies. I mean, the system is known for it. Obviously, every health system can't lay claim to that same distinction. That said, you guys were clearly driven to make a move based on your internal risk assessments, despite having what most would be deemed to be a highly sophisticated existing security infrastructure. So would you please share why Yale New Haven made finding a solution for IoT cybersecurity a priority?
Yeah, I think a lot of that, it sort of starts from, specifically at Yale, we're attached to a very prominent medical hospital or medical teaching facility with Yale University. So there's a lot of interest in research and being on the forefront of a lot of things in medicine. So that sort of ingrains itself across all of the health system. So that's sort of our, overall culture at Yale. But one of the more important reasons as to why cybersecurity specific to medical IoT has sort of come to the forefront within our environment. So clinical engineering itself was totally separate. As recently as 10 years ago, each of our hospitals having a individual clinical engineering shop that supported their hospital and maybe the surrounding clinics, but didn't really communicate with each other. About 7 years ago, we combined all of those into a centralized system that was system-wide and was also a part of IT. So our clinical engineering department actually reports up to our CIO. So as we've been able to consolidate the department reporting, we've also been able to coordinate between the different departments together a lot more, work together on projects, work together on initiatives like what we've been going through right now with COVID. We have daily calls with the managers from every one of our hospitals. So we're all on the same page. We can share equipment. We can communicate with each other. But the fact that we're now reporting up through IT, there was an internal audit that came a few years ago that we did where we found that we weren't doing as good a job tracking which medical equipment had PHI on it. So this was something that our security officers recognized as something that they could jump on to try to push us to develop a better culture for medical cybersecurity. So our CIO, Glenn Stanton, basically was able to get about some funds that we could look to push towards this purpose, and he had the foresight to not only include his security team but to pull folks from other areas and create a team that could actually have an idea of all of what we needed to have included. So I was pulled from our clinical engineering team. We had a couple of representatives from our security team. We pulled in folks from the network team because they would be doing a lot of the actual lift to connect everything and send this information. So that was sort of the impetus of the whole thing.
Well, obviously Yale New Haven's culture is, as an early adopter, it's tuned for embracing things that are new. But in this particular realm, were the bridges between healthcare technology management, which embraces clinical engineering and biomed, and IT security already built, or did you have to build them? I mean, would you elaborate on how you've got your evaluation team together, how it was organized, and what you learned, not only throughout the process of working back then, but perhaps how those non-traditional stakeholder relationships have since evolved?
Yeah, when we were first moving forward with this project, we hadn't really had any formal coordination with our security counterparts before this point. So it really were new relationships that we were forming. Really, the only connections that we ever really had were when we had projects that we were moving up that we needed to have them do a security review on. So we would put in a ticket and they would be on meetings with us to coordinate things with vendors, and they would do their security review of the vendor solution, and then they would come back and give their recommendations, and we would move forward with the project. So we knew some of the folks in that office from that, but they hadn't really worked on actual projects with us beyond that. So putting this team together was definitely a new thing for us to all. I mean, we met multiple times a week. We started doing a lot of getting to know each other while also getting to know the solutions that we were going to start to look at. It was sort of a new area for all of us, so we started meeting with vendors and coming up with questions to ask them. But at the same time, as we would get to another vendor, we'd think of questions that we would ask them, and we'd have to go back and ask the first vendor to get an idea of how we could compare them, because we were very new to all of this. And with that team together, it made it a lot better, where the security folks would ask their security questions, and then I would be able to take that in a direction specific to clinical engineering and the medical equipment and how it's utilized in the environment. And the network folks would be able to ask their questions about the requirements for the network. And it really allowed us to make sure we were asking all of the questions that needed to be asked. And since then, after the fact, that team, we still work together a lot in a lot of the different projects that we're working on. It's now not just that we talk when there's a security review that needs to be done, but we're actually bringing questions before we even put in the security review. We're still doing a lot with the current system that we've now implemented, Medigate, and we meet multiple times a week to sort of continue to move that forward as well.
Interesting. Were there any specifics with regard to the manner in which you interrogated the solution market, or did you look at a lot of different vendors? What was your weeding or filtering process? What did it look like, and how did you get to a point where you could start to move the process forward?
Yeah, so this was about fall of 2018 where we started this process, and we basically just reached out to whatever vendors we could find. So as many folks out there may have realized, since over the last 5 years, it's sort of exploded. There's a lot of vendors out there. We met with probably 15 to 20 of them, and just sort of got an idea of what their solution looked like. And from that, and like I mentioned, going back and asking other questions and getting more information. And from there, we chose 5 or 6 that we moved into a more formal RFI. And we built a spreadsheet with several different categories of questions that we asked, that we wanted to get some more information about, and more specifics about. So then when those 6 vendors replied to the RFI, we had more meetings and asked clarifying questions. And from there, decided on a couple of the vendors that we wanted to move forward with a proof of concept on. And when we were deciding how we wanted to do our proof of concepts, we also spoke to other hospitals who had already deployed these solutions, and got some feedback on what their thoughts were and how they did things. And a lot of folks were saying that they were doing, they put one solution in, and then they'd sort of rip it out and put the other one in, and then they compare them. But to us, that didn't really make a lot of sense, because you couldn't really compare them next to each other. And you couldn't, there's a lot of recency bias with the one that you have in there right now, because it either, whether it's good or bad, whatever's happening right now is more fresh in your mind. It's harder to look back at what was there a month ago and the other solution and how it worked with your environment. So instead, we chose 2 separate hospitals, our Greenwich and our Bridgeport hospitals, which are close to each other and have similar types of equipment and those kinds of things. And it looked like it was fairly easy to plug it in, because we only needed 2 sensors at each. And we got both of our POC vendors running, and we're able to look at, maybe not comparing, what actually they were identifying, because they were looking at different environments, different networks. Not comparing, okay, this one got 70% and this one got 80%. We weren't really looking at that. we were looking at each in their environment and how much they recognized. But then a lot of the rest of it was looking at the usability of the website, the integrations that the vendors were able to do, and the interactions with them as we were going through this whole process. And I mean, it was very close in the end, but we did end up going with Medigate. And that was, from there, we've continued that process and deployed from there, and sort of just went from that POC straight into moving forward from there.
Well, so you mentioned you selected Medigate, and this is not a Medigate commercial, but so let me put it this way. Assuming there were lots of competitive trade-offs that you evaluated, your team was still looking for specific tangibles, features and capabilities, as well as intangibles, which you've started to allude to, that were important in your decision process. Would you mind taking us through kind of, what mattered most to your evaluation team and whether or not it changed as you learned things throughout the process, and perhaps provide some insights to the audience, some advice based on your experience?
Yeah, we started, obviously, the ability to identify devices and protocols, and being able to tell us what's out there. I mean, that was obviously the main point of doing this whole project from the beginning, was just knowing what's on our network. So that was very important. But one sort of difference that we recognized was Medigate was very focused on the medical equipment and really fine-tuning their ability to really dig into the medical equipment. And they were, at the time, they were pretty adamant that they didn't care as much about the IoT, regular IoT, the desktop computers and the printers and those kinds of things. So that was something that we were sort of concerned about, but we spoke with them about it, and they've since moved forward with, allowing more of that IoT information to be also displayed in a separate area on the website, which really is exactly sort of the best both worlds there, where we get all the medical equipment and the information that we want, but then our security folks can also get the other devices that are on our network at the same time from one solution. And it's not mixed together, so it's really easy to tell what's medical and what's the other stuff. So that was one really important piece that we looked at. Probably the second most important was the ability to integrate. We did, in our POC, we connected to our Cisco Prime environment, which is our access points information. So that allowed us to, within Medigate, display, hey, this infusion pump is connected to this access point, which is in this specific floor near this room. So, from there, we're able to utilize that information to be able to more accurately find a lot of our wirelessly connected devices. We also were able to connect into our firewalls and start sort of creating a tracking system of information. We didn't lock anything down, but we were able to see the tags and the information that was populated into the firewall for eventual ideas of actually being able to maybe block certain things and utilize our firewalls more effectively. Within the POC, we also looked at the installation process and how for pretty much any of these vendors, it really isn't that big of a lift. It's, this sensor needs to connect to this span port on this network switch, and we sat down and we did a network environment diagram, and for the POC, we just looked at those first two hospitals. But we only needed 2 sensors for each, whereas Yale New Haven was a lot bigger and required more sensors, but it was just, put it in this 1U sensor in our data center next to the switch, and plugged in the cables, and data started to flow. So the installation process was really pretty simple for all of these. one thing that was pretty important to me was the functionality of the web portal itself and the ease of use of searching for something. So if I have a medical device that I know that I need to find out more information about, being able to go in and search in the system was pretty important, and sort of the way that the information was displayed on there.
You mentioned,
Mhm.
Joe, you mentioned Cisco Prime, which obviously provides location and tracking capability, very important, obviously. You mentioned Palo Alto. Integrations, or how these data that are being captured or being orchestrated throughout the ecosystem, is an area of differentiation. At least the vendors would make that claim. And I think that's where an awful lot of the value to be captured has yet to come. And I'm just curious, with regard to current roadmap, short-term roadmap, are there other significant integrations that you are exploring?
Yeah, and that's definitely one of the sort of exciting things about this environment is there's a lot of potential. So one of the other ones that we did pretty quickly right out of the gates was integrating with Infoblox, which allows us to pull in all of our VLAN information. And we're going to start looking at sort of reevaluating our VLAN landscape and isolating our medical equipment into specified VLANs, rather than today the medical equipment is just mixed in with all of the rest of our equipment, which can be potential security concern. So this allows us to be able to identify exactly what those what VLANs those medical devices are on today, and be able to readjust our VLANs. So that's a big project that's going to be coming in the next year or so. We're also currently deploying Cisco ICE, and for those who don't know what Cisco ICE is, it's a network admission control system, so a NAC, and it basically allows you to control the MAC addresses that are allowed to connect to your network. And before a system like this, we had no idea what, like they could look and find out what MAC addresses were out there, but they had no idea what was a medical device and what wasn't. So being able to utilize Medigate and be able to see, hey, these are all the MAC addresses for all of our medical equipment, and being able to utilize that in how we build our Cisco ICE system, and be able to control what can connect to the network. That's another really big goal that we have in the next couple of years. We're also, yep.
Yeah, I was just going to say, anything with CMMS as an example, that seems to be a very common integration.
Yeah, we're actually currently working to consolidate our management system. So like I mentioned, we moved together into one system 7 years ago, and we've slowly been consolidating our CMMS systems into one, but we're not all together in one system yet. We're planning to do that in the next few months, actually, and that will be one of the things that we're hoping to move forward with fairly soon, would be the actual ability to send this information that Medigate is detecting into the CMMS and display all of the the MAC addresses, IP addresses, software versions. All of that really important information can be displayed directly in our CMMS system. And one of the ones that I'm most excited about is pairing that information that's coming from Cisco Prime that shows the location. Being able to put that location, actually have it update in our CMMS whenever the device moves. That's sort of a game changer in being able to do your PMs for wireless medical equipment. So you can even look on there when you're out on the floor and see that it moved in between the time that you left your shop and you got up to the floor, and now it's maybe down the hall further or something like that. So that's something that we're definitely really looking forward to being able to implement.
Medigate, as you know, is highly focused on driving operational improvements. I mean, to create the business case to justify investment in the solution. So along these lines, we heavily promote the idea that this particular technology class is capable of elevating, frankly, elevating the organizational profile of the profession and the practitioners. But there's obviously a lot of nuance here that I know is of interest to the audience, and I wanted you to share your thoughts around claims being made that there is plenty of evidence here that these operational improvements driving new risk reduction practice can in fact be monetized. Do you have any thoughts to share in that realm?
Yeah, I did some research a few months ago. I did another presentation for the New England Society of Clinical Engineering, and I found an interesting report from 2018. Is the cost of data breach report done by IBM and the Ponemon Institute. So they found that across all industries, about 10 to 14% of the ITS budget is spent on cybersecurity. But in healthcare, that number is 4 to 7%. But then the healthcare data breaches, on average, cost about $408 per record. But across industry, that average was $148 of cost for those breaches. They also found that the average time to identify a data breach was 197 days, and then another 69 days to actually contain it. But they determined that if you could actually contain a breach in under 30 days, you would save over $1 million. So just being able to take those numbers and really just think about how much is the potential loss, being able to reallocate some of the funds to be able to put in a system where you can actually prevent anything from being able to really not necessarily prevent, but to detect that something is happening a lot faster. The faster we can find it, the faster we can contain it, and therefore prevent the potential for a lot of loss of funds. There's a lot of information beyond just a breach, quote unquote. The system allows us to be able to look at a lot of potential vulnerabilities and things that security is interested in. Some from the last year were Blue Keep and Urgent 11, and Medigate pops up on our system with alerts telling us, hey, this device is potentially impacted by this vulnerability. We also have interesting examples where it tells us when things are maybe not talking to IP addresses that it should be. For example, our Pyxis machines, we found that a whole lot of them were communicating to this sort of quote unquote unknown IP address external to our system. We did a bunch of research with Pyxis, the Pyxis vendor, BD, and found that it was actually going out to Microsoft to do MS updates. But they were surprised by this because they have a server at BD that Pyxis is supposed to be communicating to get MS updates and a more controlled release of MS updates rather than just taking all of the updates. So just by finding something like that, which really wasn't in any way a real vulnerability, but it was concerning, and we found that like 2 weeks after we got everything up and running in the system. And that was just like a good example of just sort of the things that a system like this is capable of finding.
We talked briefly about more detailed device utilization metrics that are also being captured now, and I'm just curious, it's all about driving efficiency, as they say, way too often, by the way. But in terms of patient scheduling or procedural scheduling, even impacts on purchasing decisions, preventive maintenance that can now be scheduling can happen around actual usage as opposed to time. Are you headed in that direction? Is it way out in the future, or is it stuff that you feel as though that you can grab in short order?
Yeah, this was something that we started to look into last fall. Excuse me. So our data analytics team has been trying to find a way to be able to more accurately display specifically our MRI utilization in New Haven. The clinical leadership came to them saying we're having some concerns about how some of the patients who require an MRI or maybe their MRI was scheduled Friday afternoon, and the MRI in the hospital that they would normally go to is Monday through Friday, and it doesn't happen until Monday, so they're sitting around waiting for this MRI for 3 days. And so now we've started really diving into what Medigate can pull out of the flow of data. And they, as of last week, they started sending us sort of a detailed CSV file that the data analytics team ingests, and it allows them to look at what kind of scans are being done at each of our MRIs. And we're going to take that information and really look at, hey, maybe these kinds of cases can be moved to this other site in order to open up time in the MRI in the hospital, things like that. So that's really just the first example of this, but I mean, that opens up a lot of potential to really look in a really deep way at what's actually happening versus just, looking at the schedule itself, which changes constantly, things get delayed. Being able to look at the actual traffic helps us to see when things are actually happening.
Yeah, if you know the types of scans that are happening, the region of the body, for example, you can eliminate setup times and start to, focus certain types of scans or classes of scans on certain machines. There are, as you said, a number of, at the procedural level, comparisons that can be made. Very interesting stuff, an interesting area of development in the solution market right now. Well, let's address the current elephant in the room, COVID-19. I've thought about this because there was a lot of distasteful, I'll put it that way, fear-mongering going on before the crisis. But I genuinely believe that health systems are going to find out after the crisis that cyber criminals were very active and successful during the crisis. And I'm thinking about the expanded use of telehealth, remote patient monitoring. Not to lead the witness too much here, but what are your thoughts here, Joe? Please feel free to share with the audience anything you think is relevant about the crisis vis-a-vis emerging cybersecurity best practices. What special steps you took or are taking as things continue to unfold?
Yeah, what's been really important with everything going on with COVID-19 was we are fast tracking a lot of things, but we really need to maintain the processes that we were doing before that were keeping us safe. So, for example, we've deployed over 1,000 telehealth carts over the last couple months, and all those computers are encrypted. The cameras that are on them are connecting through software that we've been using in the past already, and it's all done in the same way as it would have been if we did this over a year or two. We've done a lot of purchasing of equipment to get as many ventilators in, renting whatever we can, but we're not just willy-nilly connecting anything to the network to be able to get that data. We're utilizing the same processes that we had in place already. It's at this point we've been in this crisis for a couple months, but we're starting to look at how we can really look at the data with what Medigate provides. We've been working with our device integration vendor and trying to make that data available to Medigate so that we can really look at the actual utilization of our ventilators and try to plan out maybe which campus certain ventilators should be on, and we can move things between different sites. That's some of the areas that we're really looking at. So there's really a lot going on, but while we're doing things really fast, we're still following those same processes. We're still doing security reviews for new systems that are coming in, and trying to make sure that the actual security and safety of our patients is still kept in mind.
Interesting. I'm thinking here, have you got to the point where you're actually creating dashboards that are, let's call them COVID specific bundles, where it's a little bit more high profile with regard to the status and network posture of the devices that are used in treatment, or where are you in that process? Just curious.
Yeah, we created some dashboards that allow our C-suite leaders to quickly look at how our system really is, what state we're in, like how many beds we have, how many ventilators we have. Over the last couple months, we added a lot of capacity, turned PACUs and med surge areas into ICUs. So constantly it was changing the number of available beds, the number of available ventilators. And a lot of that stems from information that's available in Epic. But the information that we're looking to get out of Medigate and looking at our device integration in the future will, if this happens again, we'll have even more information to be able to display on a dashboard like that.
Well, terrific. We're right at about 2:40, and we wanted to make sure that we left at least a third of the hour available for questions. So, Linda, if we want to get started, and how are we looking on that front?
Lots and lots of questions. Just to prepare you. Right, number one question that has come in is, please specify the difference between IoT and IOMT. Some areas use these two terms exactly the same.
Yeah, I guess it sort of depends on how your system views things like a computer or a label printer. Those are things that I would designate as IoT. But some areas consider that a medical device if it's being used to run your EMR or print out lab labels. The IOMT for us is specific to things that clinical engineering and the lab teams and radiology all support within our health system, that are actually used on the patient or used to process patient samples and things like that.
Yeah, FDA class can play into this. I would say that Medigate tends to look at it at a very high level as to whether or not the device stores and transmits PHI. That would certainly put it squarely into the realm of what we refer to as IOMT, the Internet of Medical Things. There are clinical apparatus that do not do either, that are part of a category that is somewhat differentiated from general IoT because the protocols can be exotic, undocumented. And then within the general IoT realm, again, you can start to look at things as diverse as facilities based IoT, meaning smart HVAC systems. I mean, we've even seen elevator complexes in that category because, again, if they're compromised, they can have a shutdown effect. So more generally, the endpoints continue to be further classified underneath the IoT umbrella, but where we really separate IOMT, I think, has an awful lot to do with whether or not they store and or transmit PHI.
Okay, that's great. Another question here is, did YNHH spread the cost of the Medigate subscription across multiple cost centers since it really benefits multiple disciplines, or does CE solely bear the cost?
So it's not CE, but it was the ITS overall that bore the cost. I mean, CE itself reports up through IT, so that even if we had, it would be through IT. But this was money that was designated by our CEO and our CIO for that purpose. So it was not spread across any departments. It was specifically IT funding.
Okay, and following on that, how does YNHS handle connected devices and manage cybersecurity with its IT staff?
So there's a lot of stuff that we're planning to do in the future, now that we know what's out there. But up until this point, it was sort of a different situation at each of our sites. But we've been starting to develop more policies that we'll be implementing. We developed a specific medical device security review that when new medical equipment gets purchased, our Office of Information Security plans on utilizing. That'll allow us to get a lot more device-specific information beyond their regular security review that they would do, that they do for any system, which could be anything from a computer to a program to an MRI. So now they're actually going to have a medical device specific version of that will allow us to get a lot of the information that we need. And some of the things that I mentioned before, trying to isolate our medical devices into specific VLANs, that's an initiative that we're going to be starting pretty soon, but we're not yet doing. So that's definitely future for us to be able to implement those.
In terms, Joe, as a follow-on to that, core functionality includes naturally exposing any known vulnerabilities on devices that are already connected to your network for targeting your mitigation and remediation efforts. There's also the ability to digest newly published threats automatically and have them correlated to the devices that are potentially impacted. Has that information, that alerting capability, filtered into Biomed in such a way where folks who are, by contrast, hunting and pecking, are now able to actually go? Have you seen the efficiency gains?
Yeah, I mean, we're still fairly fresh in how we're utilizing the system in that way. But all of the vulnerabilities that we've gotten in the last 6 months or so, I've at least been involved with seeing that information coming in Medigate, using that to find what we have out there, and reaching out to people at each of our sites who may be more responsible for the equipment, to work with them and then work with the vendors to make sure that we follow whatever mitigation is required. And sometimes they knew about the vulnerability beforehand because maybe the vendor had already reached out. But a lot of times we're bringing something new that was just released and they didn't know about.
Interesting.
Okay, and another question here is, in what way is imaging files access included in what you are doing to provide secure access to information by doctors and nurses, both inside and outside the medical facility?
Can you repeat that one more time?
Yeah, in what way is imaging files access included in what you are doing to provide secure access to information by doctor and nurses, both inside and outside the medical facility?
So I'm assuming that's asking about PACS, but I actually don't work with PACS. We have a clinical imaging team that does work with our PACS system, and we use, I believe it's called Visage, that they use to allow clinicians to be able to view the images. They can, I believe, launch it through Epic, which should be available through Citrix, which they can connect to externally if they're at their house or on their phone. Even at times they can pull those things up, but I'm not exactly aware of the whole system and how it works because I don't support that specifically.
Okay, and I've got a question directly for you, Joe, from attendee. What is the CMMS you are planning to integrate with Medigate?
So I was asked not to specifically say.
Okay.
We haven't deployed it yet, so I think that's still sort of, we're not at a point where we can talk about that yet.
No, it's secret, yeah.
I specifically asked the question earlier and I was told to try to not talk about it. So.
Okay, all right, okay, we'll move on quickly, don't worry. It was mentioned that Medigate is displaying alerts about Bluekeep for Joe's team. How does Medigate help Joe's team remediate Bluekeep vulnerabilities versus just saying there is a problem?
Well, Medigate does offer, recommended things in the site, but I even, especially with like Bluekeep, it's really working with the vendor is usually the solution, and finding out what they're doing about it. So whether it's an update that they're working on to be able to allow us to implement and things like that. It's what Medigate generally offers is, you know, the recommendation for how to move forward, but a lot of the times you still need to interact with the vendors to be able to do anything.
Yeah, there is now coordinated with all alerting. It's one of the advances in the system, a recommendations tab that does deliver stepwise instructions on how to remediate the vulnerability, complete with links to the manufacturer, you know, the relevant manufacturer URLs and any other information that has been pulled from or scraped from the web, which is also part of what Medigate is doing on a continuous basis. That particular capability is reasonably new, and you know, new for Medigate means a few months ago, and it's probably, as you're aware, Joe, already gone through a couple of updates. They've poured a lot of energy into making sure that the insights are matched by recommendations.
Right, exactly. Yeah, and so like Bluekeep specifically is like a Microsoft update that would need to happen. So, you know, a lot of vendors, it comes down to them validating that the update is, you know, safe to use in their system. So generally need to reach out with them and work with them to make sure that you can move forward with updating. And just as a note, usually they don't require that they go back to the FDA for approval for those kinds of things. It's usually just an internal review process that they need to do to enable us to do those updates.
Okay, moving on. How are you balancing medical device utilization and failure rates, along with the scheduling of preventive maintenance to get predictive maintenance?
So we're not doing anything with that yet. I think as we get further along with how we're using Medigate, there will definitely be some planning to be able to get in and do our PMs in a predictive way, I guess. Being able to look at how much a certain device is being used will enable us to know, you know, it's been used this many times in the past year. So maybe if a certain device is being used more, we can do a PM more frequently, or if it's not being used as much, being able to maybe scale back. But also looking at the specific timing, like maybe it's only used until 4 o'clock every day. So if we do our PM at 5, it'll be available. So there's a few different things with utilization that you can look at.
Yeah, I would only
Okay.
add to that, Joe, that having that kind of visibility and being able to base your PM around utilization, for example, opens up a nice situation for procurement and supply chain folk who are behind the scenes negotiating service level agreements with vendors. They can start to look at those negotiations a little bit differently and do so without wasting their time, because they're actually going to be in a position to enforce better SLA terms as a result of having access to the information. So in terms of lifecycle management or extension, I think there's value there as well. Would you agree?
Yep, definitely.
Okay, so following on that, I've got another question about that. Does the product provide insights on scheduled maintenance or preventative maintenance that is useful or can reduce costs?
So since we haven't connected with any CMMS system yet, that isn't there, but that would be something that I would be interested to know if Medigate does when you integrate with a CMMS. Tom, do you know that?
I did not catch the last few syllables of Linda's question, if she would repeat it.
Okay, does the product provide insights on scheduled maintenance or preventative maintenance that is useful or can reduce costs?
Oh, yeah, that's the point. The insights around utilization or usage versus time is a step forward in terms of improved PM scheduling. We even look at, and this is something, Joe, that I'm not even sure you're aware of. You may have seen it update in some of the new parameters that are taken into account in alerting. But we're starting to look at, with the help of the health system, what the cost ramifications are during a PM cycle, or when a system is down, or when older systems are taken out of service relative to fleet replenishment. All of those metrics are being captured now and reported on in the system.
Okay. How easy was it working with your cybersecurity team at YNHH?
It's been very fluid. It's been a good relationship that, now that we have the better introduction of working together on this project. I talked to Chris, who's the OIS lead on the project with me. He and I probably talk multiple times a week on assorted other projects. So, I now that I have that connection, I can utilize his knowledge for other things that come up whenever there's another project and we have a question about how we should deploy something. It's a lot easier to be able to reach out to him and be able to ask a question versus having to put in a ticket and wait 3 days to get a reply. So it's definitely been a very very fluid process in how we've moved on and been able to work together through everything.
Yeah, I would just add that, and it's by no means exclusive to Medigate, but the audience should know that most all of the vendors in the space at least make the claim. I know that we do it, integrate with CMDB, ServiceNow being the the rock star in the space, so to speak. So that integration has been long since been operationalized and mature.
Okay, that's great. Another question here is, how important is medical device integration to your EMR for rented and borrowed loaned equipment, such as ventilators and infusion pumps? And how were you able to fast track those implementations?
So for the rented equipment, that is of a model that we already integrate. So for ventilators, for example, we have Avias and we have some Draeger ventilators. So that equipment, we made sure to mount our integration equipment on there when we rented it. We put in purchasing for new mounting and cabling pretty much right when everything started to hit the fan. So we were ready for those things. A lot of the other we call them secondary events, so all the ones that we've gotten from the state, those ones we've not integrated, and those are really just like if they really need them, that's when they pull them in and they're going to document manually with those. For infusion pumps, we haven't had to rent any infusion pumps. If we did rent, we would have them connected to our network, and we would do the same thing. We're not currently integrating our infusion pumps. We are actually in the middle of starting a project to do pump integration. When all this started, then that was delayed. We actually just had our first meeting after a couple months now today to start kicking that project forward again. But yeah, it would be the same sort of idea where once we had that integration up and running, if we were to rent 200 pumps, they would obviously be connected to our gateway system, and we would need to create the records in Epic, but it would be a fairly seamless creation of those records to keep track of that and allow that integration.
Okay, we've got time for one more question as we're coming up to our hour. What resources or guidance is available for conducting risk or vulnerability assessments on medical devices?
Well, one thing that's really helpful that Medigate provides is it has a lot of the documentation that you might need. So your MDS2s, when we go in and are looking at new equipment that's coming in or equipment that's already out there, A lot of that information is actually available in Medigate because they've collected a lot of that. And I know some of the other vendors do that as well, where you can actually come in and download your PDF and take a look at the filled out MDS2 document that the vendors provided. So that's one of the more important things to utilize to do a analysis of the security of a device.
Yeah, the MDS2 forms, I'm glad you brought that up, are basically crowdsourced. And it took little or no time, given Medigate's footprint, to have essentially comprehensive coverage across most of the spectrum. So yeah, the MDS2 forms are provided right alongside all of the attributes that are displayed for every device profile. So all very handily put together.
That's great. And we have now come up to our hour. So thank you, Tom and Joe, for a great and very informative webinar. And thank you again to today's sponsor, Medigate. Just a quick reminder that the post-webinar survey and certificate process is automated. So the survey link will be included in the follow-up email, which you'll receive in about an hour's time. Once you've completed the survey, you'll be able to download your certificate immediately. If you have any questions, please contact us at webinar@mdpublishing.com. And for more information about all our upcoming webinars, please visit our website, webinarwednesday.live. So thank you once again, Tom and Joe, and for everybody for joining us today. We hope to see you next time. Stay safe and enjoy the rest of your day.
Thank you.
Thanks, Joe.
Thank you, Tom.